All right. Hey, everybody. It's Michael Shermer. It's time for another episode of The Michael Shermer Show. My guest today is Dr. Michael Osterholm, Regents Professor, McKnight Presidential Endowed Chair in Public Health, and the founding director of the Center for Infectious Disease Research and Policy, CIDRAP, at the University of Minnesota. An internationally renowned epidemiologist, he has been at the forefront of public health preparedness, has led many outbreak investigations of international importance. Oh, could one of those be COVID-19 by any chance? And he advises world leaders on the ever-growing list of microbial threats. He's the author of the New York Times bestseller Living Terrors. In his podcast series, Osterholm Update, COVID-19 has been downloaded by more than 8 million listeners. His new book, here it is, the big one, How We Must Prepare for Future Deadly Pandemics. Are you telling me that this 5-year thing we just went through was not the big one?
I wish it were, but it's not.
Oh, my God.
Unfortunately, we have other viruses out there that could kill much more effectively and could be transmitted likely as efficiently as we saw with COVID.
Wow. Okay. Well, but by the way, are we done with COVID-19 and that pandemic?
Well, I think the pandemic's done. We're not done with COVID. It is now here, and it's going to be permanently here.
Yeah.
I don't think we'll ever see a day when it's not. But fortunately, we have, between having had COVID and developing some immunity from that or from the vaccines, we just see many, many fewer severe illnesses. And, today we're averaging about 150 to 160 deaths a week, which is still substantial, but it's hardly in the thousands and thousands that we saw back during the height of the pandemic.
Okay, so, and you're confident that those are deaths above what would the normal background rate is?
Right. These are deaths that are actually due directly to COVID, that can be attributed to COVID, not something else. So, if I had a heart attack, but I also had, been infected with the COVID virus around that time, we would have considered that the heart attack.
Right. Okay, so one of the conspiracy theories that's been floating around, and I track most of these, is that the doctors are not recording the deaths properly, so we don't have real numbers.
Yeah, and that's just simply not true. Can I say that every death is recorded exactly as we would think it would be relative to cause? No, I can't say that they all are, but the vast, vast majority of them are. I hear people often saying that we're also cooking the numbers, because if you look at the estimates of the number of deaths on any one given week that might come from CDC through state and local health departments, and then you see the same number of deaths looked at a month later for that period of time, and you'll say, well, they're not the same number. Well, it turns out that we report out initially the deaths by just the report of someone submitting it to a health department, but then ultimately we look at all the death certificates. And so think of it just like the business world, where we have corrections all the time for, number of jobs lost, number of jobs gained, and every month they'll go back and revise for the previous month. And so the final number that we use in this country actually is one where the death certificates themselves have been evaluated, and then they'll account for that.
Yeah. Okay. So we're 6 years out, I guess. Let's just kind of rewind the tape for a moment. We're late fall, early winter of 2019, going into 2020 is when it leaks out of the lab or from the wet market. We still don't really know, right? And
Yep.
I mean, yeah, so I watched your Rogan appearance. I listened to your entire book, and then I watched the 2.5-hour Rogan appearance you had, the second one.
Yeah.
It was impressive. And at that point, you said, we just don't know. We don't have enough evidence. Where are we now?
We're never gonna know.
Okay.
We just aren't.
Okay.
It could have been a lab leak. It could have been a spillover from the wildlife into humans. And my whole message has been, let's move on, please. Why? Not because I just don't want debate, but because we need to be better prepared for the future. And we're spending so much time looking backwards. We're doing very little to get ready looking forward.
Yeah. Okay. And then I guess if we had to make a list of, the things we did right and the things we did wrong, now that it's over and we can look back and learn from what we did or didn't do, how would you summarize that? Go ahead and take as much time as you want.
Thank you. Well, I think the first part of that question is really about what were the conditions, it might say, on the ground when this all first emerged. And what it was, in fact, people thinking of this more like a hurricane. It's going to blow through, it's going to be dangerous, it's going to be devastating, but we'll quickly go into recovery, within days to even several weeks. Well, that's not the way this was at all. And as you may recall, if you mentioned listening to the Joe Rogan interview, in early March, I indicated I thought that this was going to last at least another 18 months at that time. And I said that we could easily see 800,000 deaths or more. And I think people were aghast at such a, estimate and how I was scaring people needlessly. And in fact, 18 months later, we were at 780,000 deaths. And what people didn't understand is we wouldn't go into recovery right away. We were going to have to live with this day after day after day. And so I think one of the mistakes that was made early on was in thinking that it would be over. We did things like lockdowns. I wrote a piece in the Washington Post in March of 2020 saying, do not do lockdowns. They will not work. Why? Because you would have to maintain that lockdown likely for 3 or more years, and which was just not physically possible. Even the Chinese, which did lockdowns in some parts of their country for 2 years, found that as soon as they released these people from lockdown, they acquired the virus circulating around and still died in the millions. And so what I had proposed early on in the pandemic was, in fact, look at this more like snow days. Lockdowns are things where you're trying to keep from getting infected. You're not going to keep from getting infected with the virus, this infectious, if you have any kind of public interaction at all. But rather, what would we was the most important thing that we could do to actually save ourselves from dying, and that was to have good medical care. And if you have your hospitals at 140% census, there's no way you're going to have good medical care. And so, what if every day, every hospital published their census? In other words, how many beds were taken? And once you got to 90, 95%, at that point, you tell the world, we're going to have some snow days here, okay? Please reduce your public contact. Schools may want to be closed at this point in time, bringing people together. Bring the load of virus in the community down so you have fewer people hospitalized. That's going to get you through the pandemic a lot better. People just didn't see that though. And if you had done that in, multiple waves, it might have required 10 times to have done that during the pandemic, where the numbers go up, you knock them down, they go up, you knock them down, but you always have good medical care. So that was an example of a mistake right out of the chute because people just didn't have, I guess, for lack of a better term, that creative imagination to imagine what this virus would look like.
Okay, so that's one mistake. You mean closing everything, schools, restaurants, sporting events?
I think for the snow days, you want to reduce as much contact as possible. And first of all, let me just say, Michael, that there was such a misunderstanding what lockdowns were. 41 states announced something called a lockdown in the end of March of 2020, but many of them were like the state of Minnesota, where in fact the governor declared basically a stay-at-home order, except for essential workers. And you know what? 82% of our workforce in Minnesota is declared essential. That wasn't a lockdown. And yet it was lifted by early June. And so when people talk about the economic impact of the pandemic having really been as a result of federal policies or state policies, that's just simply not true. What it was the impact of a pandemic virus that were killing thousands and thousands and thousands of people. People had fear of going in public places. So I think that at that point, we need to understand that only because we need to be better prepared for the next one. So we not get caught by surprise and redo all the mistakes we did with this one.
Yeah. Well, in your book, and by the way, it's such a great read. I mean, I didn't even look to see, besides you, who the co-author was, and I'm listening to this thing. It's like, this reads like a Hollywood script, and it turns out your co-author is a Hollywood screenwriter,
Well,
Emmy Award winning.
Yeah. Well, we came upon that with our editor actually at Little Brown, and it was really to help people understand what we were actually experiencing at the time, then to look at what are the issues addressed. And so the device we use here is we actually tell a very, very realistic story of what the next virus could look like. Even to the extent that it emerges in Somalia and Kenya, we had every camp, we had every hospital, we had every laboratory, we had every airplane flight, all down as real time. And we vetted that with the people in their location. And of course, we did it throughout and so when we dealt with the issue on mandates or the issue of communication, the issue on vaccine development and antivirals, all tied back to a part of the scenario in such a way that you could understand why we were talking about that nonfiction part of it at the time we were.
Mm. Yeah. Well, it's pretty scary. I mean, I guess we escaped the big one, although it was still pretty bad. What would a big one look like, just like in terms of the rate of death
Yeah.
compared to
Well,
what was the rate of death of COVID-19?
well, it was about 1.5%. But let me paint for you a real story here. This is actually unfolding before us right now. When you look at coronaviruses, this is not the first time our human population has encountered a disease-causing coronavirus of real serious nature. We've always had coronaviruses that were ones that kind of called common cold. But in 2003, SARS appeared, as you may recall, in China and parts of the world that were quite devastating. And that was a spillover from animals. We confirmed that for certain. And that particular virus, though, wasn't that infectious. There were some people that were what we call super spreaders that enhanced it. But we were able to bring that under control. And actually, I was part of that response program because at the time I had been sharing my activities with the Department of Health and Human Services following 9/11 and my work with bioterrorism and the University of Minnesota. And I was still there doing that. And, what we found was we could actually stop SARS dead in its tracks by just getting in early enough and making sure all the contacts around them were isolated. And that virus killed about 15 to 20% of the people that it infected, not 1.5%. Well, then along came MERS, Middle Eastern Respiratory Syndrome, another coronavirus in 2012. That one emerged on the Arabian Peninsula, and this time it came from camels. And I had served as an advisor to the royal family of the United Arab Emirates, so I was actually in the Arabian Peninsula working on this, saw it firsthand, and I was absolutely struck by this 35% case fatality rate. Well, again, the same thing as SARS, it wasn't that infectious for most people. A few super spreaders, we could isolate them, we could stop it, and then it stopped. Well, unfortunately, we had a second uprising, you might say, of MERS when in 2015, a gentleman who had been in the Middle East returned to his home in Seoul, Korea, and actually had picked up MERS while there, brought it back to Seoul, and there was a large outbreak there. Same thing happened again. I actually went to Seoul, Korea, and worked at Samsung Medical Center where there was a large hospital outbreak. And just to see the severe illness that occurred. Well, guess what? We now have documented viruses that have the ability to be transmitted like COVID was, highly, highly infectious, and now have the machinery on board, the genetic machinery, to kill like MERS or SARS. So imagine if we had the next pandemic, instead of killing 1.5% of people, it killed 25% of the people. And this is not, again, science fiction all, on steroids. These are reality issues. We've actually isolated viruses like this now from various parts of the world. And so is it a matter of time before they spill over into humans? Sure could be. But you can imagine the chaos, the destruction, and frankly, the panic and fear that would occur if you had a virus killing a quarter of the people.
Unbelievable. Yeah, it's good to remember HIV was 100% fatal.
Absolutely. And unfortunately, it's coming back because of our destruction of PEPFAR and in many of the low and middle income countries. We're going to see, again, large numbers of people dying from HIV/AIDS.
Due to what again? Say that again.
Well, PEPFAR, which was the president's program for basically dealing with HIV/AIDS, started by President George Bush. Actually, we have been treating individuals in many of the low and middle income countries with very cheap, literally pennies a day kind of drug treatment. And we have saved probably about 30 million lives from this. And we have completely stopped transmission from infected moms to their babies by making sure the mom was on drug therapy at the time of the delivery. And we've basically destroyed all of that entire network in the last 6 months. And we're no longer doing that. And so we're going to see a major resurgence of HIV/AIDS again in this world, probably likely much more severe than we saw in the 1980s.
I forget what that was part of. Was that part of that USAID?
That was
program?
USAID oversaw this. Yes, it was part of that whole program package. Yep.
And are you worried that RFKJ is, as an anti-vaxxer, is going to undo a lot of things like that?
Well, let me just say that, again, from a context standpoint, I have served in a role in every presidential administration since Ronald Reagan. I was involved with the early days of HIV/AIDS. In Trump 1, I was a science envoy for the State Department, go traveling around the world on behalf of our government, trying to get countries ready for the next pandemic. Don't think I did very well based on what happened a couple of years later. And then, of course, on the Biden-Harris team, I was part of the COVID response group. Um, and I also served at the state health department here in Minnesota for 25 years before I moved full-time to the university. And during that time, I served 2 Republican governors, 2 Democratic governors, and we affectionately say here in Minnesota, 1 independent wrestler, Jesse Ventura. And no one could tell you my partisan politics. I am just a private in the public health army. My job is to call balls and strikes. That's it. And so when you ask me a question that may seem as if it has a political undertone, I'll answer it by just saying I'm calling balls and strikes. And yes, I'm very concerned about what is happening. And even this week, looking at the meetings that were held at the CDC from this new advisory committee on immunization practices, it's a scary time.
Mm, right. It's unfortunate. It's become politicized. At Skeptic, we've tracked the anti-vaxxers since the early 90s. And then the whole vaccine autism with the fraudulent paper in the Lancet that got withdrawn. We've tracked that for years. It seems like that's a done deal now. How is it that anyone can still hold on to that? What do you think the motive is there?
I wish I knew. I wish I could understand it. How you can not accept the kind of scientific data that exists is beyond me. And, it's not just about vaccines. It's about a number of different health issues across the board. And at this point, though, that group has not been in the position of power to dictate to the vast majority of people who are not in that crowd what they can do with or without their vaccines. They came today within one vote. Literally, it was a tie 6-6 with the chair breaking the vote to require all individuals before they get a COVID vaccine to have a prescription from their doctor. Well, you and I know how many people in this country don't have doctors. They can't get automatic access. And would that not be a deterrent to getting vaccinated? Wow, a big one. And so that's the kind of thing where Mr. Kennedy had said in his confirmation hearing, I'll never take vaccines away from people. And of course, that's exactly what's happening right now.
Yep. What bothers me about him, I guess, is that he says he wants to follow the data. He doesn't want to be wrong for 1 minute longer than he should be. Show me where I'm wrong. And lots of people do. I do it all the time, but I don't know him. But people that know him send him, here's the paper you're quoting from. Here's what it actually says. And he doesn't respond like, oh, okay, I got that one wrong. And it's like, that tells me well, of course, he's a lawyer, not a doctor or a scientist.
Yeah.
And a lawyer's job is literally to just win the case, to win the argument. That's it. And I think it's maybe it's just a lifelong style of cognition that he's developed. You just never say you're wrong. I don't know.
Can I just add a piece here? Because I just to tell the truth as it is, the second time I was on Joe Rogan, we got into a discussion where we disagreed on a point of information. And I happened to have one of my graduate students out in the waiting room there listening to this thing. And I said, look, he's got his computer here. We can go load this up and I'll show you the data. Okay. Joe said, fine. So we stopped the recording, went out, did it. And of course, it showed what I had indicated. Joe came back on afterwards and acknowledged that and moved on. I was really impressed. I was very impressed.
That. Yeah, no, he's good about that. Surprised Jamie didn't look it up for you on the air. He's usually pretty fast about those sorts of things.
Yeah. Well, that's true.
Some things are harder to find.
He is. That's very true.
The other piece, I think, is because we don't really have a full understanding of the cause of autism. So where we don't have a cause, that's where, conspiracy theories or imagination or this and that, and everybody has a theory and they do their own research to come up with stuff. And if you're a parent of an autistic child, it's got to feel like somewhat satisfying, like, there it is right there. Okay, now I have that closed and I can think about, what to do next, rather than no one knows. It could be genetics, could be early development in the womb, who knows? And that's just not satisfying.
I think one of the other things is that there seems to be a sense of this is an out of control epidemic. And that then gives you reason to think there's some cause that if we just find it. Well, in fact, the data are really very, very clear that we haven't really seen a big increase in autism. What we're doing is, by definition, just defining it differently and then calling people today as with an autistic diagnostic rubric, when in fact they were there 20, 30 years ago, but we didn't call them that.
That's right.
And I think that by itself is a challenge today, just to help people understand the spectrum. It is a very, very important issue, and I don't want to minimize it for a second, but you've got to understand what's going on to actually then try to determine what is it that's making this happen.
Yeah, RFKJ says he's going to announce in September the discovery of the cause of autism. And I don't know, last week he said Tylenol in the third trimester of pregnancy that women take. And, but that never really followed up with any data to show that. So I don't really know.
Yeah.
But I agree with you that's been our conclusion at Skeptic. It's just broadening the category of what goes in that bin of autism has just gotten larger and larger. Yeah. So, okay. So what about school closing? So I had David Swig on. He's a journalist who wrote a book called An Abundance of Caution. So here's where the conspiracy people, and it becomes politicized, is that by the late summer of 2020, it was clear we did not need to keep the schools closed. Closed them in March, and it was like we should reopen them in the fall. And Trump said, yeah, we should reopen them. Well, actually, according to David, the teachers union said, yeah, we're going to open the schools in September. And then Trump said, I think we should open the schools in September. And the teachers union said, in that case, we don't want to open. So it became sort of politicized. I don't know what your thoughts are on that. But the question is, who knew what when? Did they keep them closed even knowing they shouldn't have? That's where people get angry and conspiratorial.
Well, I'll say it's all backwards. And I talk about this at some length in the book. And this, again, was another one of the surprises, you might say. So when COVID first landed here, and you look at what it was doing to kids, it really was not creating the same level of serious illness that we saw in other age populations. In the first year, 199 kids died from COVID. Okay, but if you look at year 2 and 3 with the emergence of the Delta variant and the Omicron variant, all things changed. 87% of the deaths in the first 3 years of the pandemic occurred in year 2 and 3, most of them in year 3. And so all the studies that were done in that first year were valid. They were not, in fact, making things up. But what they didn't understand is how it was changing in kids. And by the time we got to year 3, we had actually very good studies showing that about 80% of the transmission in households originated from school kids' infection. And so what we did is we closed them earlier when, in fact, there was this idea of a snow day would have probably worked very well. When it got later, we kept showing everyone the results from the first year, saying, and this is what David did. I don't agree with his conclusions. Basically, is that year 2 and 3 was when it was really bad. And that's when, again, snow days should have gone in. And I remember when Omicron came wiping through, we had, the mayor of New York saying, come to school, the safest place to be, our schools are safe, when in fact we had massive transmission of Omicron ongoing in the schools at that time. So I think that's the part that people missed, is that we needed to be current with the data. We needed to be able to tell people exactly what was happening. If you was one of the kids in that 87% that died in year 2 and 3, as opposed to year 1, you would say, wait a minute, you told me this wasn't a problem. Again, using snow days. Don't lock down. We don't lock down for, months on end when, in fact, we have a big blizzard out here in the Midwest. We are locked down for maybe a couple days. We could have done the same thing with schools, monitor what's happening. And I think that's a major lesson for the next pandemic is it's not all or none. It's how do you measure what's happening? How do you gauge your activity then that way and proportionate to that? So if you have massive transmission going on, lots of cases, severe illness, school's not the place to be. But that was very limited time periods in the pandemic.
I see. Okay, so your snow days model going forward would be have in the books ready to go. We're going to close the schools the moment the rate hits this number, and then we'll reopen when it hits this number.
Exactly. And everybody would know then. I mean, it would be a very public, apparent thing. It's like the Dow Jones. They could read it every morning to see what level we were at. Okay. And then they would understand where the decision making was coming from. I think part of it was there was never really clear to the public. How did this decision get made? What was it? And so it became an issue of, oh my, they're doing this behind closed doors. There was some political issue. I saw the same thing. I got really in the middle of the issue with the George Floyd quote unquote riots. And the idea that we were critical of the Republican Party for holding a national convention where there was transmission and some very notable people got sick and died. But nobody in public health condemned the Floyd riots. Well, guess what? The Minnesota Department of Health here actually did extensive surveillance after the riots occurred. So that time period, as they ended for the next several weeks, there was no increase in COVID at all here. Why? Because at that time, as the effectiveness of the virus is, it was outdoors. Well, guess what? That changed because then as we got into year 3 with Omicron, we actually saw outdoor events resulting in transmission. We had concerts where people were standing close together, not with each other, and yet we could show a whole pocket of people who got COVID that night from being at the concert. So then our recommendations had to change now and said, it's not perfectly safe to be outside. Okay. And this is what you need to know. So that kind of information just didn't get shared. And if it had, I think people would have understood this wasn't trying to be political. This was just trying to use the data because, in fact, many of us wanted to know, could we be outside in large groups together and be safe? No, early on you could be, later on it was a challenge.
Yeah, that makes it even more complicated because then you're going to have to tell the public in sort of Bayesian terms, here's what we know, here's our priors, here's our credences this week, this could change tomorrow. And people like, well, but do I open my restaurant or not? Well, yes and no, depends on people just want, you're standing there,
right.
You're at the microphone, they're just asking, what do we do? We want the answer.
The problem with this, Michael, is that the variants by themselves so significantly change the transmission. That's why we kept seeing these peaks. We'd see a surge, cases would go way up and way down. I got caught in the middle of this because I was on Meet the Press just before Omicron hit. And I made the prediction at that time that the darkest days of the pandemic were still yet ahead of us. Well, you had guys like Nate Silver and others that just pummeled me, saying I was scary. I was, basically not, because the case numbers had come down at that point and Omicron was just starting to take off. Well, guess what? More than half of all the people that died after that comment I made. Okay. It was the darkest days of the pandemic. But if you had looked at each surge, we're now in a dip. Well, but it's going to come back up. Now we're in a dip. It's going to come back up again. And people weren't educated to understand this is like bad storms coming through. You're going to get the first wave and the second wave and the third wave. And just because it improves between waves doesn't mean that the next one 2 hours from now isn't going to hit you even harder. And we just didn't share that in a meaningful way.
Yeah. I thought Anthony Fauci and Francis Collins could have been a little more nuanced in their pronouncements. Is this also related to the flatten the curve idea?
Well, flatten the curve is something that I still don't know what the hell it means. Okay.
If you don't know.
So I mean, it's kind of like, remember what I said a moment ago about what happened in China when they had these people in lockdowns for 2 years without vaccinating them. They released them. And then it was like the first days of the pandemic as we saw it in 2020, because they were basically all naive to the virus. They didn't have any immunity and it wiped through them quickly. And so part of the problem was flatten the curve kind of meant the idea of we could do things to make it not be so high or be a big peak. Respiratory protection surely played a potential key role with that. The vaccine played a key role. I find it really frustrating right now because I was one of the real cheerleaders for the Trump administration work on Operation Warp Speed. I thought they did an amazing job with this vaccine, and they should get full credit for it. Now, today, we're finding it bashed by many in this administration, which seems pretty inconsistent in the sense of where it first came from. But one of the things that we didn't do with that vaccine was tell people, we know with coronaviruses that you get an initial immune response, and then it tends to wane over the next months, much like flu virus does in flu vaccines. And when we first had those results and I talk about this in the book, that appeared, amazing, 94, 96% protection at 2 months. Everybody interpreted that we're done. We got it. Well, guess what? We should have continued to follow those cohorts of people that have been vaccinated and said, well, how you doing at 3 months? How you doing at 4 months? How you doing at 6 months? Because that was where waning immunity would likely occur. Guess what happened? In the summer of 2021, when we saw these outbreaks, a number of locations among people who had been vaccinated 6 months before, What if we had told them, we're going to follow this every month and we're going to tell you what the level of protection is. And we may need to get you back in for a booster. And we'll explain why that's happening, just like we do with flu vaccine every year. Nobody challenges that. They understand we need to get a new boost every year. Again, those are examples of things we could have done differently communication-wise. I think that would have helped all of us get through this together.
Yeah. Okay, along the lines of what we did right and wrong, testing and contact tracing.
Well, contact tracing for me is like chasing the wind, okay? When you have a highly infectious virus like this with an incubation period of 2 to 4 days, meaning from the time you're exposed to the time you're infectious, and in many cases infectious well before you even get sick, there's no way you can do contact tracing and have any impact. And we poured a tremendous amount of money into this, employing thousands and thousands of people to be contact tracers. And our group actually wrote a piece early in the pandemic saying, this isn't likely going to work, and this is why it won't work. Now, it works really well if you're talking about a sexually transmitted infection, not going to be out there, blowing in the wind. If you're talking about a tuberculosis exposure, but for a virus with wings, and that's what I call the flu virus and coronavirus, that's not going to work. And so literally by the end of about 18 months into the pandemic, people begin to say, wow, this is a waste of money. It's not giving us what we needed. And we need to learn that for the next pandemic to say, if you got a virus with wings, forget it. Contact tracing is not going to fundamentally help you.
Okay, let's talk about masks and also aerosol-related transmission. You make a distinction in the book. I'm trying to remember. I think it's the droplet size, right?
Yeah. Well, when we're talking, in fact, if you and I were in the same room right now, I'd be pelting the hell out of you with my droplets. Okay. I mean, you've been to concerts where you're in the first row or two, or you've been to plays,
the singers are spitting at you.
Exactly. Okay, those are droplets. And that's normal. That happens. And they fall usually within 6 to 8 feet. Okay. Aerosols are those fine, tiny particles that you don't see that float in the air. When you can see them some days, though, is in your house when a window is there and the sunlight comes blowing through and you see all this dust floating in the air and you think, oh my God, that's in my air, Well, that's what an aerosol is. If you're walking down the street and all of a sudden you smell cigarette smoke and you look up and you see somebody 30 feet upwind from you, that's again an aerosol. That's where this virus is being transmitted. And to give you an idea how infectious this virus could be with aerosol transmission, I worked up an outbreak here in Minnesota when I was at the state health department some years ago when the Special Olympics were held here in the state of Minnesota. This was for the world. And the opening night session, there were 63,000 people in the stands of the Hubert Humphrey Metrodome, and all the teams marched in from basically a door out in right field, a big garage door, and then circled through the infield and outfield of the baseball stadium, and then they plopped down at a certain location for the next 2 hours of the program. Well, the A country, Argentina, was right on home plate, and wouldn't you know, they had a young boy who was just breaking with measles. And it ended up spreading measles throughout a number of people who were there as a participant, a coach, a player, whatever. But there were all these fans that the only contact they had with the entire event was just that opening night session. Well, we had a cluster of cases that occurred associated with that opening night. We had not had any indigenous measles in Minnesota in the 5 previous years, and these were all local citizens. When we plotted out where they all sat in the same location, of the same section, in the far, far right field where Mark McGwire couldn't hit home runs on steroids, okay? It was at 428, 450 feet. When you look at the airflow that came off, it turned out that the air came out from behind home plate, and then it moved all the way up in the air, and it went in an outtake vent up right where they were sitting. And it infected every one of them in that section that had not previously had measles or had been vaccinated. Now think of that. That's how infectious that is, okay? And so when we were talking about indoor air, for example, this was a huge issue. Now, on the other hand, and we did a poor job. Public health still is doing a poor job understanding aerosols and droplets. And this is where, I was very critical of one of the groups at CDC who continued to promote this as droplets. WHO blew it. And it was interesting because the chief scientist for WHO, who retired 2 years into the pandemic, on her exit interview with the media, she said the one regret she had was how badly they handled the aerosol issue. She said that. Okay. Well, so what could we do about it? Well, this is where it got very challenging for me, because the only thing that would really stop you from getting infected was using what we call an N95 respirator. Now, they're very different than a mask as such. They call them masks. And why are they different? Because, first of all, they're a very tight fit, okay? When's the last time anybody used swim goggles that leak through the lens? They leak through the seal, okay? But, if you have a tight seal, then if you have something in front of you that obscures the air, you're going to suffocate. You'll have the claustrophobia. Well, what happens is the material that's in an N95 is actually a special electrostatic charged material. It's made. So the air spaces are big enough so the air moves through, but it traps the virus as they come into there, or if you're infected when you're breathing out. N95s, you could have two people in the same room cross from each other for 24 hours, each wearing an N95, and there would be no transmission. If I sat in that same room and I had nothing on my face and you had a bandana on, you would likely be infected within 10 to 15 minutes. Okay? And so we had to try to help explain to people that, and many hospitals were some of the biggest problems we had. Everyone was wearing surgical masks. Well, they leak on the sides. They have no filtering mechanism at all. And so one of the challenges we had was, how do you help people know that what they're doing is not helping them? The chin diaper, how many people wore them down here?
Yes.
And how many people wore these things that just weren't effective?
I like people driving around with the mask on alone in their car.
That's exactly right. And there was a time and place to use them. And so we need a lot. And one of the things we talk about in the book is we urged at the time that there was be a major effort to improve on N95s, basically make them much more consumer friendly. 90% of the N95s that get used in this country are not in hospitals. They're actually in work areas for construction, for chemical exposure, etc. And what could we do to make a better one that fits easier, that doesn't make it feel like you're claustrophobic, that works just as well? And of course, none of that's happening. That would be a major, major advantage if we could distribute those to people, the ones you could wash at home and actually have them reusable again. So that's the kind of things we try to talk about in the book. What are some of those technological issues that we could be dealing with right now that would prepare us much, much better for the pandemic?
Yeah, that's the excerpt you guys gave us for Skeptic, which we really appreciate, because it's really disturbing to read how useless these other masks are, the painter's masks and all that stuff. But back to the kind of conspiracy stuff, didn't they know that when they told us to wear masks and everybody went out and bought these cheap masks or the painter's masks?
Well, they didn't. And again, I don't want to say that we had it all right here, but we wrote many pieces early on in February and March of 2020 saying the only thing that's going to work right now is this N95. And, again, I went to loggerheads with a number of my colleagues who said, you don't need to wear anything. Take the masks off. Don't buy them. Okay. And that was not true. I think the other piece to this, which is a very important message, is the fact that all the work that we did building all these plexiglass shields, they were useless. It was hygiene theater. It was hygiene theater.
It's such a great term.
And because all the air, if you and I were across from each other right now with this shield in front of us, and you were smoking or I was smoking, you and I would smell it in a moment. That's what is there. So one of the things we would encourage people is, please don't invest in that kind of issue. It makes no difference.
Right. Okay, so you're probably between the aerosols and the droplets, like at the salad bar where they have the plexiglass. That's good, so you don't sneeze into the salad bowl or whatever. Or the surgical masks do prevent the doctor from.
They don't. Let me tell you this. You're not going to want to hear this one, okay? At least if you're going to have surgery.
I've had surgeries.
There have been 2 studies done now, really well done, where they followed physicians who were doing surgery, where half the time they wore a surgical mask and half the time they wore nothing. And guess what? The infection rates in those wounds were identical in both studies. They were identical. There was no protection whatsoever. Why? Because that surgical mask doesn't really stop you from things blowing out and dripping down into there.
I see.
And so we need to even educate our healthcare workers about, not transmitting what they have in terms of viruses, and they need to do a better job of their own kind of respiratory protection.
Yeah. Okay, the 6 feet social distancing, where did that number come from? And
That's how far droplets typically go. So
I see.
people who thought it was a droplet thing said 6 feet. Okay, useless, absolutely useless.
Okay, let's talk about the concept of mandates. That's back in the news again. Here's where it becomes kind of political, and the issue between individual freedom and liberty versus a social collective action problem that we all need to do to solve to make society better. So we all agree to drive on the right side of the road. That's mandatory, and everybody's comfortable with that. Or you have to be 18 to vote, or
Or you got to put your child in a car seat in the back.
Yeah. These are motorcycle helmets, so on.
Yep.
These are, I guess, we're just used to that. But there's something different about vaccines. I don't know what it is. It's like putting something in my body that's foreign. Yeah. You go ahead, you do it, but I'm not doing it. People kind of have this feeling like I should have choice over my body.
Well, let me just say, this may surprise your listeners here, but I actually wrote a piece, again, published in our local paper here. I opposed mandates when they were being imposed on our university employees and students. And I support mandates overall. So what was that all about? Why was I inconsistent? Well, one of the things you have to look at with vaccines is, number one, do they stop you from getting infected? Number two, do they stop you from transmitting the virus if you do get infected? And then number three, basically, what's the risk to someone getting that vaccine versus not getting the vaccine and the disease? And it turns out that if you look at mumps, measles, and rubella, you look at polio, those are highly effective vaccines. They stop you from getting infected. They stop you from transmitting. So then it becomes a community good. If you have enough people who can stop that transmission, you can protect people who, for example, we have more and more children that have underlying immune conditions, where if they get vaccinated, their vaccine take may not be really good. But now they're in school, and we don't want them exposed to kids who could basically have been rendered non-infectious if they'd been vaccinated. So I actually support mandated vaccines there. But if you look at influenza and you look at COVID, those are vaccines that don't stop you from getting infected. They don't stop you from transmitting the virus. But do I support them? I sure do, because they do a lot to stop you from getting seriously ill, being hospitalized, or dying. To me, that's a hell of a benefit, okay? So, but the point of it is that they are separate buckets. And what we needed to do is explain that to people, why we call these vaccines the ones that should be mandated and these not. Because these are about community good. Just like you just said, you can't decide which side of the road you want to drive on, okay? It's not your choice, okay? Because that helps protect not only you, but it protects whoever you're going to hit head on. These vaccines that are really effective, that stop transmission, that stop these diseases, and that, we've looked at the United States, and if you just look at the number of deaths prevented by vaccine preventable diseases, a really well-done study from 1994 to 2023, routine vaccines saved 1.1 million lives that would have died. So so I think from that standpoint, we can show the data that just as it is using your car seat, using a seatbelt, it saves lives. And so I will continue to support them, but I'll also say for the issue of COVID and flu, give them your best data. Show them why they want to get vaccinated. I would, any day of the week, take a vaccine that could keep me from dying. I'd say that was a pretty good deal.
Yeah. Yeah, we needed more of you and less of Anthony Fauci, I would say, on the news. Although you were out there. I mean, you did Rogan twice. That was good.
I was out there.
The joke about the woman's watching the news, and there's a story about some lone nut driving on the wrong side of the freeway, and she realizes, oh, that's the road my husband takes to work. So she calls him and says, there's a lone nut on the freeway going the wrong way. He goes, oh my God, there's hundreds of them out here.
Okay, I'll remember that from a public health messaging standpoint.
Yeah,
okay,
exactly.
Yeah.
All right, let's talk about treatments: hydroxychloroquine, ivermectin, remdesivir, vitamin D, Paxlovid, Tamiflu, retroviral medicines, monoclonal antibodies. Just take your time and just go through whatever you want.
Well, I think,
what doesn't.
Let's just say that the standard drugs that we have heard over and over again about being used, hydroxychloroquine, ivermectin. There has been no clinical benefit shown from those at all. And in fact, they can actually be dangerous. And we have seen reactions to these drugs being used in an uncontrolled way. And, again, I have no horse in this race, no financial issues, no psychological or, emotional issues to any drug. I'll take whatever works. Okay. And when you look at what was found to work, one's a common one, metformin, which is a type of drug we use in diabetes and so forth. It actually had an impact on saving people's lives because it reduced the immune response that was killing the people. Okay. But then when you get to Paxlovid and the Tamiflu in terms of flu, those actually have clear demonstrated data showing that they reduce serious illness hospitalizations. They're not perfect. We need better drugs. So what we don't want to do is basically use these other treatments because it only messes up what you're putting in someone's body and what the reaction can be. And so, when you put an anti-parasitic drug like ivermectin into somebody's body, it's not benign. And so that's the last thing you want to be doing, okay? And so I just think we have to keep trying to educate people why this is not a conspiracy. This is not someone trying to keep your loved one from getting the treatment they need. In fact, it's just the opposite. And I have to tell you, one of the more really hard moments in all of this pandemic was watching some of my very, very dear colleagues who are intensive care docs literally being sued by family members who wanted them to put their son or daughter or father or mother on ivermectin or hydroxychloroquine, when in fact the data were clear and compelling. They were a much greater risk than they were a benefit.
Yeah, one of my cycling buddies is a doc, and in the early days, he said, "Oh, you got to take this." I think it was the hydroxychloroquine, but it might have been. No, I think that was the one. Anyway, so I just got a dose and started taking it, and I work out every day. And my wife says, "Your sweat really stinks." It's like, oh, so this is not just completely benign. It's doing something.
No. It was. Yeah, it was. So, and I'd be the first one to tell you if something was working, take it,
Yeah.
Take it.
Well, okay, but so like you make the point in the book that, if we're preparing for war, you can't wait till the outbreak of war to start building your aircraft carriers. You got to have these in the system ready to go. So if the big one is coming in the next decade or so, what would you recommend the government have in the way of treatments?
Well, first of all, let me just say that we have to understand what we're up against. And what I mean by that is when you look at what we spend on defense today, and I'm no expert in this area, so I'm not proclaiming to say it's enough, not enough, whatever.
But it's a lot.
But when you look at the fact that more people in this country in this century have died from microbes than all the wars combined, okay, you'd think that would be an enemy we'd want to take on head to head. Well, we're not. And the other thing is we tend to fund what work we do in this area both almost year to year. Well, and that's where when you raise the aircraft carrier, an average time period for building and constructing an aircraft carrier is about 15 years. And from the very start of the design plans to the end, they make a budget for that, okay? Well, I am actually an optimist when it comes to pandemics, and that's what keeps me going is because I think we can develop much better flu and coronavirus vaccines that could be available. In the first wave of the pandemic begins, it could be used across the world and basically shut it down. Now, what are we up against now? If we had an influenza pandemic today, our capacity to make vaccine for influenza is limited by the fact that we grow most of it in embryoed chicken eggs and in cell culture. In the first 12 to 15 months of an influenza pandemic, we could only make enough vaccine to vaccinate about a quarter of the world. That's it. This would be a horrible situation. On the other hand, if we had mRNA vaccines available for influenza as well as improved ones for COVID or coronaviruses, we could make enough vaccine in the first year to vaccinate the world. The difference between those two scenarios are millions and millions of lives. So what did we just do? We stopped our $500 million investment, only $500 million when you think about defense, to actually make these vaccines and do the research to make them better and better. So it's not just about an effective vaccine, but how quick can you make it? Okay? You can have the best damn fire truck in the world, but if it takes you 3 days to get to the fire, what good have you done? And so this is where this administration, we're trying really hard to help them see the fact that they want to invest in this area because this is what's going to be the insurance policy against a newly emerging pandemic. And I would love the fact one day that I could sit back and watch a pandemic begin, but quickly get snuffed out. That would be an amazing gift to the world. And that, Michael, one of the reasons I'm here, I'm sitting here at my desk right now and I'm paying attention to you, mark my word, okay? But I have an electronic picture frame on my desk next to me here, my daughter gave me, and it has all my grandkids. Every 30 seconds, a new picture of my grandkids comes by, okay? So if things get tough on a Zoom call, I always have that little distraction over there. That's why I do what I do. This is about my kids and grandkids, and I would love nothing more than to have a vaccine one day that we could take all this off the table.
Okay, vaccine injuries. Is it just a statistical law of large numbers? If you give, a billion people something, even if the injury rate is 0.0001%, there's enough stories to fill the evening news and people panic?
Absolutely, it is important. Injuries do occur. And the question always is a risk assessment. And let me just give you an example. You're driving down the road today, and all of a sudden you're in a crash. And they're trying to get you out of the car because it's on fire, but your seatbelt jams. And guess what? They don't get you out. You burned to death. Now, you could make the argument we should immediately take seatbelts out of cars. But then when you compare it and say, well, how many lives were saved by seatbelts? Okay. Then do you want to take them out or not? And so this is the challenge we have. There are, in fact, events that occur. We actually had 6 people die when they got the original COVID vaccine that was made by Johnson and Johnson from basically a blood clot kind of condition. But then and that was picked up quickly and that was stopped. That vaccine is no longer available. We do safety studies all the time on vaccines. It's constant, day in and day out. We have a system out there. And so I would say to anyone, again, the risk of disease versus the risk of vaccine. And let me give you one more. Even with the COVID vaccines we found that young adolescent boys into young men would develop a thing called myocarditis, an inflammation of their heart. Okay. And it was clearly associated with getting vaccines too close together. And when we spaced them out, actually, after the first year, it disappeared. But at the time it was occurring, 2 things. One, these were very mild cases. No one was ever seriously ill. 2 is that they occurred at a rate much, much, much lower than would myocarditis from actual COVID infection. And the COVID infection causes of myocarditis were actually often severe cases where people could die, okay, and so forth. So which vaccine, you're going to take the vaccine or not? You're going to run the risk of getting COVID and getting a myocarditis case that kills you, or getting a vaccine, getting a very mild case that occurred at a much lower frequency than it did with infection, and it's not going to hurt you. You're going to be in the hospital no more than 1 or 2 days. And that's the kind of thing that's hard to get across to people. I can't tell you how many times in outbreaks that I worked up as an epidemiologist and medical detective, where parents would say, any risk for my kids is just too great of a risk. So does that mean you send your kid to school or you don't send them to school? And so we often have a hard time actualizing risk, particularly when it's about ourselves and our kids.
Yeah. Well, I was glad to see you correct Joe on that. Well, not correct him. I mean, he had Robert Malone on talking about
Yeah.
myocarditis. And then to his credit, he had you on and you explained it quite quickly like you just did now. It's like, oh, okay.
Yeah.
So, I mean, that's how it goes in an open society. We just allow the skeptics and the experts or whoever, just to have their say. Can you, I was just going to make a comment about a number from your book. It was like the rate per 100,000 who died was like 900 something per 100,000.
Yeah.
Peak
About
of
a
COVID.
little. Yeah, it was actually a little, about 1 to 1.5%, depending on the age of the population, underlying health conditions. And, we as a country did poorly relative to the number of deaths. But you know why? One is we are a population that has a lot of underlying health problems. Look at obesity. Obesity was a major risk factor for severe outcomes, okay? We had as a country goes, we had so many underlying health conditions. I mean, when you look at our incidence of diabetes, you look at those things. So
Obesity.
part of the death issue was not just a regular number. It was about what did you come in with to begin with in terms
Right.
of risk.
Well, the reason I brought that up is because, whatever the exact number is, but 900 per 100,000. The murder rate, the homicide rate is 5 per 100,000. And people think this is just astronomically too high. It's only 1 per 100,000 in Europe. So 900 per 100,000? Yep. I mean, that's how serious this is.
It is.
This isn't even the big one.
And that's why we keep talking about it. People would say, why would you write another book? I was at, again, HHS, Health and Human Services, right after 9/11. Tommy Thompson brought me in because I had been very involved with bioterrorism work, and of course, anthrax happened. And I was there for the early days of the 9/11 Commission. And I have to tell you, Michael, that was one of the most positive experiences in my career. I watched nonpartisan leaders come together, very objectively evaluate all the failures, no finger pointing. We got to get them out. We got to figure out what happened. We can't let this happen again. And what lessons could and should we have learned? And I was inspired by that effort. I have called for, and I started this well into the early days of the pandemic. We need a 9/11-like commission for COVID that would actually, on a bipartisan basis, we're done talking about Wuhan. We're going to agree to disagree and just say, we don't know. Was it a spillover? Was it a lab leak? We don't know. But we've got to be prepared for the future for either one, because either one could happen in the future. If we had that, I think a lot of these discussions we're having could have been avoided. People could have acknowledged what the challenges were and what we could do. So I'm still hopeful that somehow this book, if nothing else, will help precipitate the fact, because I point out in here, warts and all, there's no shine on this to make any of us look better. It's about what the hell happened so we can figure out for the future.
Well, on that, I also had Jay Bhattacharya on the show, and now he's high up in government. And he was the co-author of that great Barrington Declaration. I think you were partially critical of that. I don't know. When I just kind of glossed over it, it seems like he got some of it right. But is some of it right? Some of it's wrong? Or how do you assess
Well, I
it?
think, I think the part that he got right was the fact that, this virus is going to transmit widely. But what he came away with was that once you had it, you were done. And that was not the case. Okay. And so one of the challenges we had is, it's one thing to say you're going to isolate certain people from the virus, but can you really isolate people away for 3 years? People who had underlying health conditions. They never accounted for the fact that we had so many people at high risk in this country, because of these underlying health conditions. Just add up the number of people that are on statins or insulin, et cetera, and you realize, oh my God, we have a lot of people. They thought you could just bubble these people away, and that was never going to be the case.
Yeah.
That's where my snow days come in. We were going to take casualties. Our job was to try to have as few casualties as possible.
Yeah. Yeah, I had Eric Topol on the show recently. He's got a new book out on longevity and trying to live a long life. Not forever.
Can I tell you, he's one of my dearest friends.
Oh, good.
And I just was on a call with him this morning.
Oh, nice.
He is, I think, the most brilliant health professional I know.
Wow.
The guy is just, he's brilliant, and his book is outstanding. I'd urge anybody to go buy his book too. And, and he just knows so much about so many aspects, and he thinks futuristic in a way that very few people do. So yeah, it was good to have him on here. He's good.
Yeah. Well, what I liked about it is that it's realistic, not just optimistic about the future, but realistic. I'm not promising you're going to live 500 years if you do these things.
Or would you want to necessarily?
Yeah, that's exactly right. Well, this is what I say to the longevity people, the futuristic longevity people is, don't you want to live to be 500, Shermer's? Like, can you get me to 100 without Alzheimer's? Well, no. It's like, well, then just solve that one first, and then we could build from there, right?
Yeah, and make sure my joints keep working for a while. Yeah. So you're
exactly.
absolutely right. Okay.
Yeah. What was I going to say? I was going to say something else about that. Oh, well, anyway. So, okay. So the big one is, would you say, you do say in the book, it's not if, but when it's coming.
The pandemic clock is ticking. We just don't know what time it is.
Yeah. I mean, it's like the asteroid that killed the dinosaur. It's out there somewhere. It's going to hit again.
Well, and what people don't realize is the risk today is so much higher. Why? Because these viruses originate largely in the animal population. Well, with 8 billion people on the face of the earth today, with bushmeat becoming one of the most frequently consumed meats in the whole world, bats are now today an item of food in many countries of the world. They carry these viruses. And then we have so many animals, such as if you look at poultry today, it turns out poultry is the fastest conversion of energy to protein. So why do we have so many chickens and ducks and turkeys out there? Because that's where it's at. Well, that's what influenza virus loves. They love that kind of an environment. So we've created a world today where we actually speed up the virus movement within themselves, but also to humans. And so, it's not our great grandfather's world anymore. And that is one of the reasons why we have to be prepared now to say it's not likely going to be 100 years from now at all.
Yeah, you talk about modeling in the book and how difficult that is to make projections. I guess the question we want to know is for the next one. So is the next one going to be like COVID-19? It's, worse than the flu, but it's not the Black Death. Or is it like the Black Death and, this is catastrophic? So closing the schools and the economy and all that would be a good thing if it's like the Black Death. Not such a good thing because it has its own costs if it's just like COVID-19. But the problem seems to be, well, how do you know which one it's going to be?
Well, it's interesting. As an epidemiologist, my favorite four-letter word is data.
Data. Yeah.
Data. I need data. Okay.
Not anecdotes.
Yeah, exactly. Yeah, exactly. And I think that's what's important. And that's what we have to also understand how to share with the public. You just don't clobber them over the head with a bunch of numbers. You say, what does this mean? And so instead of reacting the same way to every situation that may be very different in terms of, what's happening with transmission, et cetera. We had a 2009 influenza pandemic that was actually quite mild in the sense of number of cases. It killed a lot of pregnant women, ironically. But in fact, again, he handled that one very different than COVID. And so we have to be prepared also to be flexible. But we got to tell the story of what we're doing, why we're doing it, and what it means to you, what it means to your family, what it means to your job. And I think that's the kind of thing. And as you know in the book, we also tried to cover the economic issues. We talked to a number of really, I would say leading edge economists who said, what we did surely was in response to, but we could have done it much more like the Europeans did, where people didn't lose their jobs. They kept their jobs. You got paid to do it that way. And it actually allowed the workforce to come back much more quickly, than just sending money out to people who now no longer had a job.
Yeah, maybe I know you got a hard out coming out here, so maybe that's a good place to wrap it up, is a comparison method of what other countries did as experiments that we can learn from. Who did the worst and who did the best and where were we?
Well, again, we surely led the world by the vaccine development. I mean, we saved millions and millions of lives by what we did. It's too bad that we had to find ourselves challenged to get this vaccine to people, particularly in red states, that last year of the pandemic, particularly with Omicron around. We also came in with really the worst health profile in terms of at risk for dying, with all the underlying conditions we have. I think that from a standpoint of communication, et cetera, nobody got it exactly right. When you look at Sweden versus Norway and Finland and Denmark, they have these big debates. Sweden did it very differently. The first year of the pandemic, they had much higher death rates than the other countries, okay? But you know what? By the time the pandemic was over with, 3.5, 4 years later, they were identical. So, I mean, again, that's what you have to be able to understand is that we're in this for a long haul. And you can't have a solution that's just, for the next 2 or 3 weeks. Do not do any more lockdowns. Don't close borders. Here we were. We thought we were so talented in our ability to keep this virus out. We fortified the Western coast, all the ports, all the airports, okay, because it was in China. Well, hell, it went around the world to Italy and then came into New York City and hit us on the East Coast. Like, what was that about?
It's like the plexiglass barriers. They
Exactly.
don't do anything.
It's just exactly that way. So again, just once this virus starts circulating around the world, it's gone. It's gone.
Yeah. Amazing. All right, Michael, thank you so much. Here it is, the
Thank
big
you.
one. Get it and read it and be scared. No, it's like a movie. It's like one of those Hollywood films about, I forget, there was the one with Dustin Hoffman was
Contagion.
in there. Yeah, Contagion.
Contagion.
Yeah, it's like,
yeah.
You're, the opening 10 minutes or so of every chapter is like, oh my God. But it's realistic. That's why we really should prepare.
Yeah. Well, thank you for having me, and thanks
All right,
for
Mike.
getting the message out.
Okay, happy to do it.
Bye-bye.